Welcome to the High Efficiency Practice, a podcast focused on how leaders build more efficient healthcare and wellness businesses. Hosted by Brenda Mana, the show explores what works across operations, growth, and performance. Today's guest is Susan Frank, a healthcare strategist, nurse, and founder of ASF Solutions, with more than 30 years of experience across clinical care, payer systems, and healthcare operations. Throughout her career, she has worked at the intersection of patient care, compliance, and revenue optimization, helping hospitals and physician organizations improve documentation, reduce denials, and build more efficient systems of care.
Welcome, Susan. Today, we'll be diving into rethinking traditional billing and ASF solutions. I'm excited to discuss cost efficiency and smooth operations with you. Start about your background and how ASF Solutions came to be the company.
Thank you for having me today, Brenda. It's a pleasure to be here and talk with everybody that has the same struggles in a different way. Nurse by background, so never in a million years would I think I would have my own company and be doing my own thing out here. That was the furthest thing that I ever thought. Things happen and transform through 30 or 40 years, but loved being a nurse, worked in cardiac at a large healthcare organization in Pittsburgh, migrated into and then started my own company when that leadership changed, focusing on working with different organizations to maximize revenue and provide higher quality care at a more reasonable price for everybody. That's the ultimate goal. And when you look across the country and you look across the world, we all know healthcare is going up, and the challenge of healthcare is coming up with a better way to take care of our patients and a more cost-effective way to do that, and how we support our providers and our physicians and nurses at the bedside to do the best that they can do. So a lot of the work ASF does is look at different operations from front end to back end at billing and refine some of those.
Is it a trend you're seeing? Is this something you're perceiving your customers, or there's a demand for this connection between what the patient suffers and then even the healthcare providers might be not even getting paid because of the mishaps of that flow being disconnected?
You've got other pieces in there like the insurers, right? So that's another element for the provider that the patient falls in the middle of. We are not only siloed within our own healthcare system, and anybody that has had to have a loved one taken care of, the first thing everybody does is reach out to somebody clinical. Help me get through the system. Who do I contact? How do I get my bill? When you look at how a patient comes through a system, we have silos. There's various silos within organizations, and they don't speak to each other, and the patient falls in the middle of that. A lot of what I do is try to break down those silos with different work teams so that we can fix things on the front end and automate things to make work smarter and not harder. A patient comes in and a patient will have no idea how they're going to get billed or what their insurance pays for, what their co-pays are going to be. So it's an incredibly anxiety-provoking time for a patient, and trying to understand those trends that happen with payers is really hard, not only for a patient, but for the different health systems. There's a lot going on through CMS. So I do a lot around what are the rules? What are the regulations? How do people get paid within the hospital system? If the hospital system's not paid, you can't pay the nurses, you can't pay the physicians. So really trying to figure out what are those barriers to get a good bill out the door and to get it paid by a payer, because you've got another third party in there. And then how does that go to the patient? So you've got to be timely, you've got to be accurate, you've got to get it done right the first time. I'm trying to focus on my different programs so that we don't get a denial back that lets the patient wait another 60 days, 90 days, 120 days till they even know they have a bill. They'll get a bill and it's a year later, and you don't want that for patients. So there are a lot of moving parts that I help organizations work through, and then help them with how do we work with the payers better to make sure that we're doing things the right way for all the patients too.
I was thinking the integrator of all that information where you know who is this patient, where is this patient coming from, and where it's going out. And also is the same type of platform the patient sees when they're leaving, where they have the information about their treatment or ibuprofen they need to take every 8 hours because of X. Do you do this type of implementations, or you are more assessing the complexities right away way, as in doing the audit, what is not working, and then providing potential solutions to implement.
A lot of it is around auditing and then providing solutions. For electronic records, part of the struggle are they working aside. When you're discharging a patient, it would be very nice for an electronic record to have a discharge checklist to know each department did their protocol, but that lives in different pockets of the EHR. So it's not in one page for a provider to look at and know that's done. I think there is optimization that organizationally EHRs could do better at to make sure patients were sent out the door with the appropriate care and that it was easier for a provider to find that all in one spot. If I have to look at what social work says and what your care manager said and what your discharge physician said, a lot of that is in different spots. So it's hard in the electronic record. It still lives in different parts. I, as a nurse, might not be privy to a certain physician part. When you spit out electronic discharge instructions, they can be pages and very confusing for many people. There are ways we can streamline that and help patients be discharged in a better way so that they don't have to come back in the hospital. We could use the electronic record in a different way to do that.
Do you feel like the improvement in the use and deployment of this type of technologies has a regulation component to it? This clinic has issues inside the clinic which are not related necessarily to regulation, but if there was some sort of umbrella in which they were covered as in, okay, you can share this information, but within your clinic, that would ease these solutions into deployment because the complexities of the requirements and the privacy, it's a burden.
Correct. Depending on how that umbrella is, it works different in different states with health information. To give you an example, let's use my mother let's say she was in Florida and she went to an emergency department and had some fluttering of her heart. And 6 months later, she goes to her primary care doctor. The primary care doctor can't see that she had that visit down there. But unless he's asking her and unless my 80-year-old mother remembers, they would miss that. Some of the payers are working very hard because a payer can see across that continuum of those states. So if I'm a certain payer, they know my mom was down there because they got the bill. So how can we communicate in a better way to put that information in front of the physician to make sure, because that's his patient, that he can see that information consistently is a challenge in trying to be done by many organizations in a better way. Still not a great system right now.
It's not just remembering about having the visit. It's more like remembering all details. I could relate because if I go back to whatever pediatrician office I take my kids to, I hardly remember. I could have been there 3 weeks ago because life is full of information and you need at least one continuous timeline to keep that file from missing stuff. That might be important to remember by the time you need care.
I think having something like that is really important, even when you're changing medication and understanding what happened and being able to see that in a continuum, really important to keep people healthy and on the right medications. People are discharged and I don't know they're on this medication. So CVS is sending something that the primary care ordered. This person canceled that, doesn't want her to take it, but she's still getting 3 more doses. And why do these keep coming to me? We can do a lot better within the pharmaceutical system to connect those. So there's another one, which is your outpatient pharmacy filling medications. That is a tough system to pull together and a huge health risk for patients.
The risk, everything's so sensitive and time bound. It's not the same thing to treat something on the spot than a condition that boils inside and ends up being a huge problem. Back to your background and how you ended up founding ASF. How do you think your past self thinks of your success today? What did you think I was going to become when you founded it?
It's pivoted a little bit to where the need was. So I started a lot in the population health space because I love providing new models of care. And I'm very good at putting things together where we have health coach classes. We train people that they can go into the home and help a patient. But the reality is a lot of people don't pay for that. And so I had to do a lot of pivoting. Although I love that part of it and the new model of care, you really got to go into an organization and understand how to make sure they get paid for the care they're providing first. I do a lot more now on improving documentation, making sure we audit things, and that front end to the back end is as seamless as it can be to get that revenue in and paid for what you're doing. It's amazing when you do audits because we think we document a lot of things, but we don't always put in the record the things that we should. And we grow up with make sure you cover your butt. I got to make sure I said Susie's fine at midnight and she's looking great when she's on 3 drips and 4 liters of nasal cannula and taking oxygen in. And so sometimes we don't do as well as we should about putting that level of how sick they are, because we're checking on them. We're like, all right, they're stable. And that can be nursing documentation, physician documentation, cut and paste, because it's an electronic record, which we hate cut and paste.
And the auditing piece, being okay and being stable are two separate things. So it's very important to use the right word when describing pathology or situation, because it might mean completely different things.
It's interesting when even if you have utilization review nurses off site, they'll call and they'll be like, why is Susie still in the hospital? And you're the bedside nurse and you're like, they're ready to code any minute. And you're like, what do you mean? Why is she still in the hospital? But if you step back and you're the one reviewing the record and you can't tell why they're still there, we have work to do in putting that story down and understanding what's happening for the patient. Do you want to talk about pharmacy systems? That is a piece that could use automation too for patients. That pharmacist can see into what's happening with patients. And there are some great tools coming out around pharmaceutical. That is a big piece that can flag duplicate meds, make sure they're asking questions and getting back to the primary care doctor and asking, why is this coming? The sad part is your giant eagle pharmacies aren't staffed to do that kind of pharmacy intervention. I see patients that have returns to the hospital because the medications are difficult to manage, especially as patients are getting older. Coming up with pharmacy solutions is a key piece in our industry to change outcomes in healthcare.
Going to ASF and that specific aspect of it, what do you think it's not working? Is it possible? Are you able to audit and implement the right solutions, or are you having an issue finding the right solutions to implement out of the complexities of inventory, stock, and how fast people change medications and how many conditions do they have?
It's a snowball. Who's going to pay for that? Is it your CVS pharmacy? Is it the hospital? Is it the payer? And because that's a financial burden, like with these new models of care, they're not reimbursed, right? So for a hospital to try to put a new model of care up, they're doing it just to get by. But you really need an in-depth medical reconciliation. It's called MedRec in the hospital system. We're supposed to do it when you come in. We're supposed to do it when you leave. Home care should do it, but it takes time to do that accurately. That means I got to call CVS and figure out what my patient was on before, what she's on now, and make sure what CVS is going to fill for her. When you look at who is going to absorb that cost, there's not one owner of it. It's like this piece that's not owned by anybody. Until people start to come together and figure out a model of care, it becomes who's going to step up to the plate. And it's really difficult to have a solution like that. Sometimes on grants, we've been able to do that and shown with new models of care with pharmacy and pharmacists that do some of the med reconciliation. But it is a difficult piece, and finding a solution to that would bring healthcare costs down immensely.
If you've done it through a grant, even if you have very good results, is that scalable? Because one win doesn't mean that actually is going to be a win for every other clinic, depending on how integrated their system is and also how good the information flows, because that's the gap on top of the gap.
It's external, right? So you've got a bunch of people that know I have to do this, but there's not one owner of it, right? So there's just a bunch of hands in the pot. And again, somebody to absorb that cost to do it the right way, who can afford to do that right now unless they're getting reimbursed the right way?
What would a day in your life be like?
Depending on the day of my life, it could be traveling to a client and doing an assessment. It could be doing audits. It is normally back-to-back, some virtual things for a few days and normally some on-site things, depending on what's going on and where people are located. But a lot of it is project management, working with an organization to get all the players to the table and making sure those players have a plan and are able to execute the things they need to do that team comes up with. Some of that involves some coaching. Some of that involves some supporting. Some of it involves breaking through some barriers and working with that organization to say, hey, we got an issue right here. Somebody help me. So escalating things appropriately. So a lot of that is getting them to an outcome where we can see success and a good return. I'm data driven. So that's a big thing for me, that every contract I've done, there is an outcome with $1 million return that's normally ongoing. I work hard to make sure that organizations can see that and it's measurable and can keep looking at that year after year. Sustainability is another piece I focus on. Building tools to make sure as you make a change, that sustainability stays there is another important piece that needs to happen.
When you say auditing in your day-to-day, I figure some people that might hear that and not necessarily be as friendly and collaborative. So what is working well for you right now, and what might be the frustrating part of it?
A lot of people reach out to me because they know something isn't right. Why am I only seeing $1? This shouldn't be $1. Can we look at this? I work with 16 associates. So depending on the pain point, whether it's a coding pain point or it's a CMS rule or regulation, I have different people that work on my team, including physicians. Project wise, I don't have all of the answers, but I know who to call. I've got really smart people that work with me that can find out different things. The audit we use as an educational tool and not as a penalty. And sometimes we find really good things. Celebrating the successes is as important as finding out opportunity. Auditing is preventative and really trying to look at opportunity for the organization to continue to grow and get paid for the care you're providing because the documentation is there to support it.
Which metrics are you the most focused on improving? Coding or continuous improvement on cost?
A lot of it can be productivity. So looking at staff productivity, making sure we're refining services. Sometimes I'm big on not just hiring people. It's not always a person that is the fix. A lot of people put a Band-Aid by putting a person into a solution. Sometimes shuffling the deck doesn't cost you anything. Bringing those silos together, you can put those puzzle pieces together and get to the right solution by breaking that down. I focus on so that you don't go into an organization, we have to hire 6 people, right? That's not what we want to do. We can't afford to do that. So how can we be cost effective? Where do we have redundancy within those silos to break those down and build that continuum up that supports the organization differently? And it's really a puzzle. I enjoy the puzzle pieces. So let's look at the puzzle pieces and how can we do this different and better? And it's amazing when you bring staff to the table and the brainstorming that comes out of them. Some of it's this part we can't do right now, and that's up there in the pie, right? There's really good ideas from the staff within that organization. They produce a lot of great ideas of what they have to do differently, and getting that buy-in from staff is also helpful.
Sometimes it's staffing, sometimes it's reshuffling, and I would like to get your insight on how has COVID impacted staffing in general? What's your insight on that?
A lot of what I also help organizations with are clinical advancement programs for the internal staff, not necessarily physicians. That's a different topic. But internally, we don't do a great job of keeping our best and our brightest. If you can hire somebody out of school and I can train you to be a health coach, right? And then that health coach does non-nursing duties for us and then learns to do blood draws and then learns to do a monitor and then goes to school for nursing, right? You've developed a continuum of doing that. And I have a few examples where I started a navigator program, and the staff that started that, all 4 of them stayed within healthcare, went on to nursing, went on to running quality with an MHA. If you can start to attract people and have a clinical path or different paths, even in a physician office, we struggle with medical assistants, right? I don't need to have an MA to room a patient, take a wait. I can train you to do that. We could have mothers that work from 9 a.m. to 3 that room patients. We don't have to always give an injection. So having different levels, get more hands on deck that's flexible, and building those programs is really important. Breaking the mold is important because we are short of nurses, nurse assistants, EMTs. COVID had a significant hit to people in healthcare. It's scary. There's a lot people don't understand with burnout and the mental anguish that goes into healthcare providers. We need to do a better job of recognizing them, taking care of them, and figuring out how to foster growth within those organizations. I work on that with many of the people I have worked with putting in advancement programs. Physicians is the other piece of that. Physicians, we have got to come up with a better way to support our doctors as things become more complicated, including electronic records. Older physicians can't even keep up with the clicks and how to get an order in. So education and ongoing education for the entire healthcare system is super important.
You mentioned the future, and that's a segue to into the next question, which is regarding ASF and where do you see it going in a 6 to 12 months timeline? Like, where would you want to be in 6 months with ASF?
I am trying to do more education. So I think the piece I have been shy of, and I think you and I talked earlier, I'm not one that loves to be on stage. I'm the behind the scenes girl that likes to get it done and show an outcome to the people that need to see it. So for me, business wise, I want to do some more educational lectures to talk about the silos, what people can do proactively to prevent things, as well as leadership coaching is really big on my radar screen. A lot of people who are my clients, we joke, and a lot of us become friends, but they're like, you're like my therapy session where I can talk to you about venting and you have somebody who's empathetic and hears it, and they're not the only one that's been going through that, and it happens to other people. I have a lot of CEOs that are now friends of mine that need somebody to talk to as a neutral person to say, what are your thoughts on this? And what about this? Because the CEO can't just brainstorm with everybody. A lot of what I enjoy doing is helping people go through that brainstorming and that coaching and that mentorship and figure out what I can do to help support them. So I'd like to do a little more education and a little more lecturing and a little more in that coaching space.
Is there anything specific that you feel like we haven't discussed or you want to touch base on the context of the discussion about ASF, about the industry, or final remarks?
It's a huge problem, and I get discouraged because it is as they take one bite out of the elephant at a time. But I'm a fixer, and my satisfaction is by fixing things, and seeing the data behind that is important. So I think taking it one step at a time and trying not to do too many things is my biggest challenge, because I always want to get everything done for everybody and make sure we have outcomes as quickly as possible. And sometimes that's not the best avenue. So I take a step back and have to pick that one thing that's really going to help somebody. That's my piece that I continue to work on. And I think the other evolution for me is also getting leadership training out there with that coaching. A lot of organizations that don't have mentoring for leaders, and that includes physicians. So we put physicians in CEO roles, but nobody ever trained them how to be a leader or manager. They went right from med school and suddenly they're a CEO. I'd really like to work with some of them on leadership because that's been a big piece of mine for the past 30 years.
We might need to schedule a follow-up in 6 to 12 months for you to tell us how good that went. Stories and anecdotes on anonymized examples. We get a good laugh and also amazed about the findings. I agree. Things happen so fast that you eventually land in a position that you have not been trained for, even if that is being a nurse and founding a company 10 years ago, going through COVID and being able to make a hospital efficient and you don't even know where to start, or just partnering with the right people and getting it done. Thank you so much for your time.
Thank you, Brenda. It was a pleasure.